Ideally, from now till you write the paper, you should pause all kinds of sleeping. Yes, you can rest, but you shouldn't be sleeping. Okay, that is fine. All right. So, like I mentioned, we'll quickly go through all the integumentary system conditions. Okay, and usually the integumentary system happens to be one of the areas that a lot of students would not pay attention to those areas, but it can turn out that you go and they are asking you so many questions on those areas that you didn't pay attention to. For example, a condition like cellulitis is an area that they can ask you questions on. Okay, and most of the time what happens is that questions on those areas are usually very simple. Okay, but once you didn't get the opportunity to go through those areas, then the questions now turn out to become difficult for you. Okay, so example, if you take a condition like pharyngeal or a boil. Pharyngeal or a boil is a very simple condition, but if you've not been exposed to it, a simple question on it will become a difficult question for you. Is that okay? Great. So we will quickly go through the integumentary system questions. Depending on how the time would go, I think you have an arrangement to this morning. We would also look at the special senses. Good, yes. So with the integumentary system, we will first of all look at this condition. The pharyngeal or a boil is the same thing. Okay, a pharyngeal or a boil. Now, in going through, I'll highlight on some key points that would help you to remember if in case you come across these conditions in the exams. Now, if you look at a pharyngeal, it's simply a localized, painful pass-failed infection of a hair follicle surrounding a cutaneous tissue. Okay, now pay attention to this. So you see here, we have a single boil over here, a single. Okay, so anytime there is collection of pus in a subcutaneous tissue, just a single collection. Okay, so here you see it's just a single one. Is that okay? We call this one a pharyngeal. Now, if you come over here, the same thing. It's just a single collection. Okay, this one is a pharyngeal. Okay, so anytime, and this is an indication that infections have accumulated inside the blood. Is that okay? Great. And this is what we call a pharyngeal. It's a localized pass-failed infection of a hair follicle and surrounding subcutaneous tissue. Now, pay attention to the fact that you see here, the emphasis is not on the fact that the pus has failed a hair follicle alone. The pus is either filling a hair follicle or a surrounding subcutaneous tissue. Okay, again, pay attention to the fact that the pus is not occupying a hair follicle alone. So when we say a boil, it's either a pus is filling a hair follicle or a subcutaneous tissue. Now, but the key point with pharyngeal is that it's a single collection of pus, single one. Okay. Now, if you don't pay attention to the fact that it's single, you will not understand the carbuncles. Okay. Let's quickly look at the image of a carbuncle. Look at the carbuncle. You see, when it comes to carbuncle, it's like interconnected. So when multiple pharyngeals are interconnecting in a particular area, we call that carbuncle. Okay, so you see over here, it's not one. So there is one here, there is two, there is three, there is four, there is five, there is six. But all of them are interconnected or they've clustered at a particular area. That one, we call it a carbuncle. Now, their cause is the same. Their cause is the same. The difference is the fact that with a carbuncle, we are having multiple, interconnected areas having failed with the pus. Okay, let's go back and go and look at the image of the carbuncle again. So you see the carbuncle is only one. You see here, we have only one. If you look at this image too, it's only one. The pus has accumulated in a subcutaneous tissue, but a single accumulation in the subcutaneous tissue. Now come and check the carbuncle again. You see the carbuncle, there are multiples of them. It's the same accumulation of pus in the subcutaneous tissue, but multiples of them are occurring in a certain area in the body. This one is what we call the carbuncle. Okay, so when we say a carbuncle, it's when multiples of pus accumulate at different areas in subcutaneous tissue in the skin, but they are interconnected. Is that okay? So you see here, there is one over here. There is one. So here, pus is inside the subcutaneous tissue. There is another one over here. Pus is inside. There is a different one over here. Pus is inside. There is a different one over here. Pus is inside. You see, multiples of them are occurring in a particular area. This one is called carbuncle. So anytime you hear the examiner saying that pus has accumulated, okay, pus has accumulated, and they are interconnecting at a particular area in the body, then we are talking about carbuncles. Now, another thing the examiner can say is that when multiple pharuncles are interconnected in a particular area, that one too is a carbuncle. Is that okay? That one too is a carbuncle. Okay, but the moment you hear the examiner saying that a localized, once we use the word localized or a single, okay, pus accumulation within the subcutaneous tissue or within a hair follicle, then remember the examiner is now talking about the pharuncles. Okay, that's the difference. Okay, now the causative organism for both of them, the same thing. This is the commonest organism that causes pharuncles. This is the commonest organism, Staphylococcus aureus. So pay attention. This is the commonest organism that causes both pharuncles and carbuncles. Now, usually, apart from the fact that the examiner may want to examine your understanding on the difference between the two, a common question they can ask you in these two conditions is the common causative organism, and that is the Staphylococcus aureus. Now, apart from that, there are other factors that can increase one's chances of getting this condition. One of them is poor hygiene. Okay, poor hygiene. Okay, and usually especially in fat people where sometimes there are friction coming from their clothing. Okay, when you usually wear tight clothing and there are a lot of friction coming from your clothing, okay, you are also at risk of getting this condition. Okay, so you wear tight clothing, especially at your perineal area, very tight, and you are getting so much friction from your clothing, you are at risk of getting pharuncles and carbuncles. Okay, secondly, there are times that you can undergo some shavings. Okay, so you shave. There are some people, they will shave and afterwards they will experience some minor cuts, especially when you shave and you experience minor cuts. Usually you are at risk. You will notice that you may develop some kind of either pharuncles or carbuncles. Okay, so you shave and you end up developing minor cuts. Your chances that you develop pharuncles and carbuncles are very high. And there are times that someone may experience blocked hair follicles. In such individuals too, they are likely to develop pharuncles and carbuncles. Now, we have some risk factors as well, like patients with diabetes mellitus, they are at risk. Patients with very low immune system, they are also at risk. Now, poor personal hygiene. Okay, poor personal hygiene is also one of the risk factors. Malnutrition is also one of the risk factors. Obesity is also one of the risk factors. Okay, now let's look at the cardinal signs. Okay, with the cardinal signs, the commonest sign of a pharyngeal or a carbuncle is redness and erythema. This is the main sign, the major sign of a pharyngeal or a carbuncle. Redness or erythema. Pay attention to that. But apart from that, so let's go back to the diagram again. So you see the area over here has become reddish. Apart from the central region that will usually appear either yellowish or whitish, you would notice that the peripheral areas of the pharyngeal is reddish. So the area will usually appear reddish, and the area may appear swelled up, swelling. Is that okay? So the cardinal sign of this condition is redness or erythema. Okay, and there are times the individual may lose function, especially in very severe cases. Imagine you are having a pharyngeal in your armpit. Imagine there is a pharyngeal, a big one inside your armpit, and some people can experience very huge pharyngeals boil inside their armpit and sometimes in their groin area. And usually when it happens that way, you may lose function of that part of your body. Okay, activity or movement of that part of your body becomes very difficult. Is that okay? So loss of function. And of course, when it comes to the other signs, patients can experience, definitely you experience pus formation. Okay, and that is what I was saying, that you are going to notice pus formation, but usually the central portion of the pharyngeal is where you notice the pus, but the peripheral portions are usually reddish. Is that okay? So you see the central portion indicates that there is a pus accumulating here in the swelling, but the peripheral portion will usually look reddish. Is that okay? Great. So that is it for the pharyngeals. Okay, so remember the cardinal sign of this condition is redness. And apart from that, you notice swelling. And with the swelling, you will notice that the central portion of the swelled part would appear either whitish or yellowish, but the peripheral portion will usually look reddish. Okay, and the patient may sometimes experience fever, especially in severe situations. Okay, good. So remember, the causative organism is Staphylococcus aureus. Now, we usually treat this condition with antibiotics. So, and the commonest or the first line antibiotic for this kind of condition is flucloxacillin. Flucloxacillin. Pay attention to this medicine. This is the commonest medication they use in the management of pharyngeals and carbuncles. Now, remember, carbuncles is also the same thing. The signs and symptoms, the cardinal signs, the same. Just that with carbuncles, there are multiple ones that are interconnected, occurring in a certain area in the body. The management, the medical management, the nursing management, everything is the same thing. Is that okay? Yeah. So the antibiotic of choice for treatment of pharyngeals is flucloxacillin. Now let's look at the surgical management. Now, with this condition, in very severe cases, this is the condition where in severe cases, they may do incision and drainage. In severe cases, surgically, they may do incision and drainage. And at times, in severe cases, after the incision and drainage, of course, there will be a wound. Anytime a pharyngeal or carbuncle occur and the boil burst out, usually a wound will be at that part of the body, especially when it's a very severe pharyngeal. Yes, there are times that the pharyngeal is very small. So after it bursts out, usually within a short period of time, say 24, 48 hours, the place starts healing. But there are times people will have very large pharyngeals and carbuncles that the place will burst out, the boil will burst out, and a wound will be formed. Okay, there are times they may even have to do incision and drainage to burst the boil themselves, the pharyngeal or the carbuncle themselves. And usually afterwards, there will be a wound. Okay, and they may sometimes have to even do wound drainage for some time. Okay, great. Now, the priority nursing diagnosis when you are nursing these patients is the acute pain and risk for infection. But acute pain, pay attention to the acute pain and then impaired skin integrity. Now, if the examiner should ask you your priority nursing diagnosis when you are caring for a patient with a pharyngeal or a carbuncle, it's either you do acute pain or impaired skin integrity. Acute pain or impaired skin integrity. Now, if the two, you have the two in the question, go in for the acute pain and impaired skin integrity. That's the priority nursing diagnosis when you are caring for a patient with these conditions. Okay, so as a nurse, if you are caring for this patient, pay attention to trying to assess the size of the boil or the size of the pharyngeal or the location of the pharyngeal. Is that okay? You have to assess patient's level of pain, the body temperature, because we mentioned that in very severe cases, patients is likely to experience fever. Okay. Again, when it comes to the position, usually in pharyngeals, we position patients according to the location of the pharyngeal. Okay, because you see, if, for example, if the boil or the pharyngeal is at the sacral region, which is the back region of the person, we want you to position the patient in a way that it won't put pressure on the pharyngeal. Okay, so we usually position the patient according to the location of the pharyngeal or the boil. Okay, when it comes to diet, because the skin is involved, it is reasonable that you give this patient high protein diet. Okay, high protein diet. Yes, and because it has got to do with infection and immunity, you have to give the patient foods rich in vitamins. Okay, and then adequate fluids. Okay, preventive practices include personal hygiene practices. So maintaining good personal hygiene, avoiding sharing items, especially razor blades and towels. Okay, great. Now, when it comes to the complication of a pharyngeal, a common complication of pharyngeal is a carbuncle. And again, remember, both pharyngeals and carbuncles can lead to cellulitis. Both pharyngeal and a carbuncle can lead to cellulitis or sepsis. Both of these two conditions can lead to cellulitis or sepsis. Okay, so usually if a patient is having a pharyngeal and it's not being managed properly, a common complication that can occur is either cellulitis or sepsis. If a patient is having a carbuncle, if patient is not managed properly, a common complication that can occur is cellulitis or sepsis. Okay, great. So that is what we mean by a pharyngeal and a carbuncle. So you see, this is the carbuncle. So when you see, this one, it's not single. There is one here, there is another here, there is another here, there is another here, but they are interconnected. The causative organism is the same, the Staphylococcus aureus. But apart from that, all the other factors like the poor hygiene, okay, if you use razor blades to shave and then you experience a cut, okay, you are likely to experience a carbuncle as well. Is that okay? So the causative organism and the causative factors are the same. The difference comes in with the nature of the occurrence. So here, there are multiple ones that are connected in a particular area in the body. Okay, so like I said, the commonest organism behind is the Staphylococcus aureus. Is that okay? The treatment is the same. Flucloxacillin, the surgical management is the same. But apart from the flucloxacillin, which is the first line treatment, the pain is also there. So you have to manage the pain with analgesics. Okay, great. So basically that is it for pharyngeals and carbuncles. Now remember I mentioned that if a patient is experiencing a pharyngeal and a carbuncle, a common complication that can occur is cellulitis. And again, another complication that can occur is sepsis. Okay, Okay, so now let's look at cellulitis. Cellulitis is also one of the common complications. They ask questions on a lot in the, especially in surgical nursing. Now, when we say cellulitis, I have some images over here. Good. I have some images over here. So cellulitis is simply an acute diffuse bacterial infection of the skin and subcutaneous tissues. Okay, it's a bacterial infection of the skin and subcutaneous tissues. So it's a bacterial infection that is within the skin and subcutaneous tissues of the skin. Okay, now cellulitis is commonly caused by these two organisms. It's either it is caused by Streptococcus pyogenes or Staphylococcus aureus. It's either the condition is caused by Streptococcus pyogenes or Staphylococcus aureus. Okay, pay attention to the causative organisms. Okay, so these are two common causative organisms that can cause cellulitis, either Streptococcus pyogenes or Staphylococcus aureus. Okay, and this is how the condition usually manifests. So I have three images over here. So this is clearly showing a cellulitis. This is also a cellulitis. Infection inside the skin or subcutaneous tissues. And usually, if it is affecting the lower limb or the leg, you are going to see that part of the body swelled up, swelling at that part of the body. So you see here, you can see how the leg is swelled. You see the leg, there is swelling here in the affected part. From here around this area, you can see massive swelling of the affected area. The same thing applies to this image. This is also cellulitis. Okay, this is also cellulitis. Is that okay? Great. And sometimes if someone experiences insect bites, it can lead to cellulitis. Now, if a patient is having a surgical wound or any kind of wound, you don't manage the wound properly, cellulitis can occur. There are other skin conditions like fungal skin conditions, another condition like eczema, which is dermatitis. If a patient is having these conditions, you don't manage the patient properly, the patient can end up experiencing a cellulitis. Okay, good. Let's look at the cardinal signs of this condition. Again, the same thing. The cardinal sign of cellulitis is also redness and erythema. Now, the signs are almost similar to that of the pharyngeal. So there too, we have the redness or erythema. We have the heat around the sites. We have swelling, usually massive swelling around the affected part. Is that okay? Then pain and also loss of function. So if a patient experiences cellulitis, especially on the legs, the patient usually lose function of the affected parts. Okay, great. So one cardinal sign of this condition is redness and erythema, and usually heat around the affected area, swelling around the affected area. Okay, good. All right, that is fine. That is fine. Now, one thing that you need to remember is that when it comes to who can differentiate between cellulitis and a pharyngeal, who can differentiate between cellulitis and a pharyngeal? What's the difference between cellulitis and a pharyngeal or a carbuncle? What's the difference? Because if the examiner should put the meaning in a context for you to choose the possible diagnosis, how would you know that this one is likely to be a pharyngeal or a carbuncle? And how will you know that this scenario is likely to be a cellulitis? Yes, how will you know? Okay, so the difference is that if you look at a pharynx, there is usually, you see clearly pus accumulation in the subcutaneous tissue or hair follicles. Remember, with pharynx and carbuncles, it's either pus is accumulating. You are going to see evidence of pus accumulation in subcutaneous tissue or hair follicle. You remember in carbuncles and pharynx, we didn't highlight on the skin. Pharynx and carbuncles, the target areas is the subcutaneous tissue and hair follicles, remember. But when it comes to cellulitis, it's the skin and subcutaneous tissues. It has got nothing to do with the hair follicles. It's the skin and subcutaneous tissues. That's the difference. Okay, and again, if you look at cellulitis, look at this condition. Can you see any pus accumulating somewhere, like the way you saw in pharynx, that there was a pus accumulation and it's appearing as a single process, or it's appearing as multiple single processes in a certain area which is connected? No, cellulitis doesn't happen like that. So with cellulitis, we are not going to see any pus at the affected part. So you see, you won't see pus, visible pus indications at affected parts. But the pharynx and carbuncle, you are going to see a pus accumulation, especially at the central area where the pharynx is. But with cellulitis, it's not like that. So cellulitis usually affect the skin and subcutaneous tissues. Is that okay? Okay, that is one of the difference. So if the examiner asks you, talks about a condition affecting the skin and subcutaneous tissue, the examiner don't highlight on pus accumulating under the skin. They are likely to be talking about cellulitis. Okay, and especially when the swelling is not localized. The swelling is a spread one, a very large one, covering a large area of the skin. The answer is more likely to be cellulitis. All right, that is fine. That is fine. Okay, so the cardinal sign still remains the redness and erythema. But apart from that, other systemic signs like fever, chills, tenderness, rapid spread of the redness, okay, may all be present. All right, now let's come to the diagnostic investigations. Now pay attention when it comes to the integumentary system conditions. I'm giving you a certain clue. When it comes to the integumentary system conditions, usually when we are diagnosing, we do what we call clinical diagnosis, not diagnostic test. Let me take you back again. When it comes to integumentary system conditions, when we are diagnosing, usually the preferential one is the clinical diagnosis. When we say clinical diagnosis, we are concentrating on physical assessment. Keep it in your mind. When it comes to integumentary system conditions, when they are asking you of how we diagnose, usually in integumentary system, we use clinical diagnosis, which we have the physical assessment and history taking. We don't use a certain diagnostic test. You see that most of the other systems that we've learned, usually there is a preferential diagnosis, which is a particular diagnostic test. When it comes to integumentary system conditions, usually we use the clinical diagnosis. When we say clinical diagnosis, we are talking about either history taking or physical assessment. Okay, so if a patient comes with a pharynx, you are not going to take blood sample to go and do any lab. Fine, that may help for other reasons. But when it comes to diagnosing the condition, we use the physical examination and the history taking. So you observe with your eye, you physically examine it. And if it is a pharynx, you will know. Okay, it's not about going to do any test. And that applies to integumentary system conditions. Integumentary system conditions. Okay, we use clinical diagnosis, or there are times that in exams they can just write physical assessment. So if a patient is having a pharynx and the examiner is asking you, okay, between physical examination and then let's say white blood cell count, Which one of them will you use for the diagnosis? Is the physical examination. When it comes to integumentary system conditions, the best way of diagnosing them is the clinical diagnosis. Okay, like the history taking and then the physical examination. But apart from that, they may do other tests, like I mentioned, the full blood count. This can help them to know. And usually, if a patient is having cellulitis, if they do full blood count, the white blood cell levels will go up. Okay, the white blood cell levels will go up. Okay, and at times, if there is a wound, there are times they can do wound swab, or if the cellulitis is very massive and pus is coming from it, there are times that they can do a swab and use the swab to do culture and sensitivity to identify the exact organism that is causing the disease. Okay, like I mentioned, the same thing. This condition is also an integumentary system condition, a skin condition. We usually manage these conditions, integumentary system conditions, with flucloxacillin. Remember, most of the integumentary system conditions, the first line treatment is flucloxacillin. Or keep it in your mind that if a patient is having a skin problem, you want to recommend antibiotics. The first line they usually recommend is flucloxacillin. Okay, flucloxacillin. Good. All right. So usually I don't even like to highlight on the others, but if there is pain, they may give analgesics, and for the fever, they give antipyretics. The same principle like the pharyngals. In very severe situations, they may do incision and drainage. In very severe situations, they may do incision and drainage. There are times that they may even have to do debridement. Okay, there are times they may have to do debridement. Now, the same thing. If a patient is having cellulitis, the preferential diagnosis is acute pain and impaired skin integrity. Acute pain and impaired skin integrity. This is the preferential diagnosis for this condition. Okay, good. So now when it comes to there's a condition affecting the skin. So apart from the assessing for the pain, assessing for the location of the affected area, the size, the redness, the warmth, how it is spreading, you monitor your vital signs because of the fever. And since this infection, the pulse may also increase. You observe patient for systemic signs and all. Apart from this, another important point to know is the diet. So the dietary management here, our focus is to boost the immune system. So you target giving vitamin C. And since a condition is affecting the skin, we need repair. So you target give the patients high protein diet and then adequate fluids. Now remember, cellulitis, one of the common risk factors of this condition is diabetes mellitus. So at times, if patient is having this condition, it's important you find out whether they are diabetic. And if they are diabetic, as part of the treatment, you should be managing the diabetes as well. Okay. So basically, that is it for cellulitis. If a patient is having cellulitis, one common complication that can occur is sepsis. Sepsis can occur. Again, there are times there can be recurrence of the condition. In fact, usually most patients who experience cellulitis, they tend to experience recurrence of the condition. The condition may occur again if care is not taken. Okay, so recurrence of the condition is very, very, very common. All right, so now we've done the pharyngals, and then we've done the carbuncles. Then we've done cellulitis. So remember, pharyngal is a single process, a localized pus accumulation under subcutaneous tissue in a part of the body. The commonest causative organism is Staphylococcus aureus. Is that okay? And the cardinal sign is redness and erythema. But apart from that, the other signs like swelling, heat, warmth are the affected area and loss of function of the affected area, especially when it is a very large pharyngal. The same thing applies to carbuncle, just that carbuncle is not a single pus accumulation. There are multiple ones, but they are interconnected at an area in the body. The causative organism remains the same. And I mentioned that a common complication of both pharyngeal and carbuncle is cellulitis and sepsis. Cellulitis and sepsis. And we came to cellulitis. Cellulitis, on the other hand, is usually an infection of the skin and subcutaneous tissue. Now, pharyngeal and carbuncle is an infection of the subcutaneous tissue and hair follicles. Is that okay? That one is a pharyngeal. But cellulitis is the skin and subcutaneous tissues. The causative organism is Streptococcus pyogenes and Staphylococcus aureus. That is for cellulitis. Okay, great. So pay attention to the differences between the three. So we are moving on. So now we are going to now look at folliculitis. Now, as we are moving on, try and understand the differences so that you will not miss it. Try and understand the differences between. So we've done the pharyngeal, we've done the carbuncle, we've done cellulitis. We are coming to folliculitis. Now look at folliculitis. An infection of one or more hair follicles. An infection of one or more hair follicles. You see the difference now. You remember, let me take you back to pharyngeal. You see, pharyngeal is an infection of the hair follicle, a subcutaneous tissue and hair follicle. Now, folliculitis specifically an infection in one or more hair follicles. So usually, especially the gentlemen may understand folliculitis very well. Usually when you shave and you experience a cut or minor cut, you realize that in the hair follicles, sometimes you develop infections and the place swells up, especially if it's on your face, your beard. You may think that it's pus, it's pimple. It's not pimple. That is folliculitis. Not only on the beard, if you shave your armpits and you experience cuts, there are times that you may experience what we call folliculitis. You will notice that there will be some processes that will arise from your hair follicles, and sometimes pus may even come from it. Now, that one specifically is folliculitis. So anytime the examiner use specifically an inflammation or infection in hair follicles alone, remember, if the examiner says infection in the hair follicles alone, that one is folliculitis. But if the examiner says hair follicle and subcutaneous tissue, that one is a pharyngeal, or it could be a carbuncle. So if the examiner goes specific and say an infection or inflammation specific in the hair follicles, then straight away the examiner is now talking about folliculitis. Remember, in fact, when I was a student, this is how I learned folliculitis. I considered it as a type of pharyngeal that is affecting, because you see, a pharyngeal is either affecting the hair follicles and a subcutaneous tissue. But folliculitis specifically a hair follicle. Okay, so if the examiner puts it in a context that an infection is that okay in one or more hair follicles, then that one you call it folliculitis. So you can see this one. You see this young man after shaving. You see the young man after shaving. You see a lot of folliculitis. This one is called folliculitis. So from today, you see someone have gone to shave. You notice some swelling as if there is a pimple at the hair, the areas where the hair is. Okay, that is folliculitis. It's not pimples. It's not acne. It's folliculitis. Okay, an infection or inflammation in the hair follicle. So you see this one. So you see this one. So you see there is pus inside though. And sometimes there is pus inside, just like you have in pharyngeals. But this one, because it's specifically occurring in the hair follicle, we call it folliculitis. Is that okay? But a pharyngeal can occur not only in the hair follicles, it can also occur in a subcutaneous tissue. Okay, but you see here, this one clearly. So this one clearly, if it come, you do your clinical diagnosis. Here, you don't need to go and do any lab. Once you see the patient, I observe and see that the swelling is under an area relating to a hair. So you see over here, you see there is a hair here, and at the base of the hair, the folliculitis is there. So usually folliculitis, one way you'll be able to diagnose is the folliculitis will be at the base of a hair. So you see, this is a hair. This is one hair. You see the folliculitis is at the base of the hair. This is the base. Here, if you come over here, this is another hair. You see there is one follicle here at the base of the hair. So that is one way you can diagnose. You see the follicle forming at the base of the hair. Is that okay? Great. That is what we call folliculitis. Now, the causative organism still remains the same. Staphylococcus aureus. Staphylococcus aureus is the same causative organism that causes pharyngals and carbuncles, that cause this condition as well. Staphylococcus aureus, the same causative organism. But when it comes to folliculitis, apart from the Staphylococcus aureus, we can have fungal infections that can cause folliculitis. We can also have viral infections, even though they are not common, that can also cause this condition. Is that okay? Great. So it's good that now you know the difference. Over here to the cardinal sign, one of them still remains the redness and erythema. You notice swelling, especially under the base of the hair. Okay, and sometimes it may be painful, especially when you touch it. The patient may experience some pain. Okay, especially when they make attempts to. And sometimes clearly you see some small red spots or pass-filled bumps at the area. So look at it. You see there are some red spots. Check. You see there are some red spots or pass-filled bumps in the area. That's the folliculitis is occurring. Okay, that is fine. Now the management. Now here, the management, usually we give antibiotics. Okay, we can give antibiotics like the mupirocin. Okay, we give this antibiotic. Clearly, it targets the Staphylococcus aureus and kills the Staphylococcus aureus. Okay, great. Now, when it comes to oral antibiotics, okay, they can also give flucloxacillin as the first line in severe cases. Okay, but usually when it comes to folliculitis, we prefer that you start with the topical antibiotics. That is one difference between folliculitis and pharyngals and then cellulitis. Usually when it comes to folliculitis, we prefer that the treatment, you do the topical antibiotics, except when it is very severe, except a situation where you can have a folliculitis that is very severe. Okay, and in that situation, then you may do a combination of the topical antibiotics and then the oral antibiotics. But with folliculitis, usually the first line, they do topical antibiotics. Okay, great. All right, that is fine. And sometimes they will give antihistamines. Okay, antihistamines. With folliculitis, surgical management is not a required process, but in very severe cases, they may consider doing incision and drainage, especially when it is very severe. It has become so severe, like a boil or a carbuncle, or a farbuncle and a carbuncle. Okay, again, the priority nursing diagnosed for this condition too is acute pain and impaired skin integrity. It follows the same observation, the same dietary management, the same preventive practices like the pharyngals and the carbuncle. Now, remember, if a patient is having this condition, if care is not taken, the patient may develop a pharyngeal and a carbuncle as a complication. If a patient is having folliculitis, if care is not taken with regards to the treatment, the patient may end up with a pharynx, a boil, or a carbuncle. And there are times recurrence is very common. Okay, it's very easy. If someone usually experience folliculitis, it's very likely occasionally or periodically that person will re-experience the condition again. Okay, I believe you've heard of this condition before, impetigo or impetigo. Okay, now this condition, look at this is a patient. Look at the image over here. Look at the image over here. Okay, so here what we say is that you can see something like an honey-colored crust. It's like a crust. Okay, so it's like an honey-colored crust at the affected part of the body. Is that okay? And this condition, what makes this condition unique or different from the other integumentary system conditions that we've looked at? I'll give you some cardinal difference. What makes this difference is that this condition is contagious. This condition is highly contagious. It can be transmitted. Okay, but a pharynx cannot be transmitted. It's not contagious. A carbuncle is not contagious. Is that okay? But this condition is highly contagious. It can easily be transmitted from one person to another. Okay, so with this condition, there is a bacterial infection of the skin characterized by vesicles or pustules. And usually, so there is going to be initially when it starts, you are going to notice something like a vesicle, like a smaller swelling, as if there is fluid inside the swelling. It will appear like a boil, but it won't look whitish or yellowish like a boil. It will just appear like a single vesicle. Or usually, I'm friend in toes. A bit in toes, small in toes. Do you get it? And when it bursts, then it will form what we call an honey-colored crust. An honey-colored crust. So, for example, you see this one. So it started as a vesicle. You see here, this patient has experienced a burst of the vesicles, but it will usually start as a vesicle. Then it will burst, and when it bursts, then it forms the honey-colored crust. Okay, and this condition is also caused by Staphylococcus aureus and Streptococcus pyogenes. So you see, these are the same organisms that causes cellulitis, remember. But Staphylococcus aureus rather cause pharyngeal, carbuncle, and then folliculitis. Okay, but these same two organisms causes cellulitis. Okay, now the key points with this condition is one, it is very contagious. Again, this one will start as small vesicles at the affected area. Then when they burst, they form the honey-colored crust. Is that okay? Yes, so this is a typical image showing patients with that condition. Okay, yes, when it comes to the cardinal sign, it still remains redness and erythema. You will notice mild pain, swelling around the affected parts, warmth. Okay, the patient may experience, so you are going to notice the vesicles or pustules at the initial stage. You see the vesicles. At the initial stage, it will appear like a small vesicle, more like the pimple, but this one, you won't see the yellowish central portion like how the pharynx will be like. It's just a vesicle. And when the vesicle bursts, then it will form what we call the honey-colored crust. And this is a cardinal sign of impetigo that you have to remember, the honey-colored crust. All right, that is fine. So of course, it's also integumentary system condition. By now, I think you've been following. So the clinical diagnosis, the key way to clinically diagnose this patient is physical examination. So you look at the characteristics of the skin problem. Then you base on that to diagnose the condition. Okay, good. Now, when it comes to the medical management, with the medical management here, we also do flucloxacillin. But of course, over here to the first line management is the topical antibiotics. For impetigo to the first line management, just like the folliculitis, the first line management is the topical antibiotics. Then they can also do, in very extensive cases, they can do the flucloxacillin. And at times they will give the antihistamines. All right, that is fine. Good. Now let's look at another very interesting condition, which is the tinea infections. And I know you might have heard of the tinea infections. The tinea infections, what we call the dermatophytosis. Dermatophytosis is the same as the tinea infections. The tinea infections. Okay, so the tinea infections are commonly, they are fungal infections. That's one thing you should know. So you see, the other integumentary system conditions, you see they are bacteria. They are usually bacteria, apart from cellulitis that can be caused by viral or fungi. The other, in fact, even cellulitis is commonly caused by Streptococcus aureus and Staphylococcus aureus and Streptococcus pyogenes. But if you come to tinea infections, they are fungal infections. So the moment the examiner starts building a story like a patient suffered a fungal, once it's something related to the skin, you hear fungal, please think about tinea infections. Okay, so the tinea infections are fungal infections that affect the skin, the hair, and the feet. Okay, so the tinea infections, they usually affect the skin, the hair, or the feet. Okay, so the skin, the hair, and then the feet. Is that okay? Good. And they are usually caused by dermatophytes, such as the tripcophyton. Is that okay? Good. Now we have about 3 types. So we have the tinea corporis, the tinea pedis. There are more, but basically we will concentrate on these 3. The tinea corporis. Tinea corporis affects your body skin, the skin. So when we say tinea corporis, we are talking about tinea infection of the skin. When we say tinea pedis, it simply means tinea infection affecting what? Your feet. Then you say tinea pedis. Tinea infection affecting what? Your feet. When we say tinea capitis, tinea infection that affects your scalp or your hair. Is that okay? So when we say tinea corporis, it's a tinea infection that affects your body skin. Corporis, tinea corporis. When we say tinea pedis, a tinea infection that affects your feet. When we say tinea capitis, it affects your scalp and then the hair. Okay, that is the difference. Okay, so pay attention. So we have, but remember that tinea infections are fungal infections. So the moment an examiner is talking about any skin infection caused by fungal as a biologic agent, quickly start thinking about tinea. Okay, so the examiner is talking about a fungal infection of the skin. Think about tinea. Fungal infection of the feet. Think about tinea. Fungal infection of the scalp and head. Think about tinea. Okay, and so depending, and I mentioned it usually affects the skin, the hair, and the feet. So if it is affecting the skin, we call it tinea corporis. Affecting the feet, tinea pedis. Affecting the scalp and the hair, tinea capitis. So let's look at the images over here. So you see this one is affecting the scalp and then the hair. So this one is tinea capitis. So you see this one is affecting the skin. This is tinea corporis. Is that okay? Tinea corporis. And when it is affecting the feet, okay, tinea pedis. So you see this one, This one is tinea pedis. Tinea pedis. Tinea pedis. Okay, so we have the tinea pedis, tinea corporis, tinea pedis, and tinea capitis. Those are the common ones that you have to concentrate on. Okay, let's look at the cardinal signs. Now, when it comes to tinea conditions usually itch. Now, over here too, we have redness and erythema. But one thing about tinea condition is that there is usually pruritus. Okay, and that is one of the points that you can use to differentiate the tinea from the other skin conditions. You see, the other skin conditions we've been talking about, from furuncle, carbuncle, we didn't talk about itching over there. But one key sign when it comes to tinea, the fungal infections of the skin, is that there is itching or pruritus. It's one of the unique signs when it comes to tinea. Is that okay? Great. Similarly, there will be swelling. There will be swelling over here. Okay, and sometimes patients may experience hair loss, especially when it is the tinea capitis. So if someone repeatedly experiences tinea capitis, it's very likely they may experience hair loss. And sometimes they may also experience burning sensation. Okay, they may experience burning sensation. Now, if it is a tinea pedis, tinea occurring at the feet, okay, it's very likely patients may experience some possible odor, okay, from the feet. Okay, especially when the person wears shoe for a very long time, remove it. It's very possible the patient may experience some odor from the feet. Okay, that one is very common with the tinea pedis. Okay, great. And sometimes for a patient with tinea pedis, it's very common that they may experience burning sensation at the feet. Those with tinea pedis. Okay, especially when they wear a very tight shoe or a very tight a very tight shoe, especially for a very long time. They may experience some burning sensations. Okay, yes, like I said, I keep on repeating that for the integumentary system condition, when it comes to the preferential diagnosis, we use the physical examination. For the integumentary system conditions, we use the physical examination. So pay attention to that. So if the examiner is trying to assess your knowledge, integumentary system conditions, we usually use the physical examination. Now, for tinea, when it comes to the medical management, the first line is topical antifungal agents. Remember, when it comes to the management, the medical management of tinea, the first line treatment is topical antifungal agents. Okay, so for example, ketoconazole is one of the topical antifungal agents. Ketoconazole. They can also do clotrimazole. This is also a topical antifungal agent. So they will do topical antifungal agents. That's the first line treatment. Okay. Again, they may also give oral antifungal agents, especially in very severe cases. So in very severe cases, they can do topical antifungal agents in very severe cases. Okay, they can do the oral treatment. But remember, the first line treatment is the topical antifungal agent. Is that okay? And then in very severe cases, they can do the oral antifungal agents. All right, that is fine. The priority nursing diagnosis still remains over here: acute pain and impaired skin integrity. Again, you can also concentrate on the infections. Okay, when it comes to the nursing management, it follows the same pattern as the management of the other, similar to that of the other conditions we've discussed. Now, let's look at the last one with the integumentary system. Now, the herpes simplex and then the herpes zoster virus. The herpes simplex, and then the herpes zoster. The herpes simplex, and then the herpes zoster. Now, when we say herpes simplex, let's start with the herpes simplex. When we say herpes simplex is a viral infection. Okay, but here it's a viral infection that is caused by the herpes simplex virus. It's a viral infection that is caused by the herpes simplex virus. Now, what is the difference? This condition usually affects the skin and mucous membrane. Look at the difference. Oh. This one affects the skin and mucous membrane. And usually with this condition, there is going to be group of painful vesicles. Usually we see vesicles that are having erythematous base. Okay, that is what we call the herpes simplex. Okay, so it's usually characterized by painful vesicles. Okay, good. Now we have the herpes zoster, which we also call the shingles. Now the difference is that in the herpes zoster, okay, it's like a patient who has suffered from a condition caused by varicella zoster virus. Which condition can be caused by this organism? Which other condition is caused by this organism? Yes, which other condition is varicella zoster virus the causative agent? Yes, which other condition do we have the varicella zoster virus as the causative agent? Yes, who have an idea? Which other medical condition is caused by varicella zoster virus? Yes. Yes, who is having an idea? Have you heard of chickenpox? Okay, so a patient suffers a chickenpox and then it reoccurs again. Okay, so you have a patient who has suffered from a chickenpox and it reoccurs again. Now, when it reoccurs again, you can't call it chickenpox. This time, it's herpes zoster or shingles. So for herpes zoster to occur, it's like a patient who have suffered chickenpox before, and the chickenpox is reoccurring in that patient again. So a patient who have suffered from chickenpox is also caused by this organism. So let's say a patient has suffered chickenpox before, and it happens that the chickenpox is reoccurring in that same patient again. When it happens, it's not chickenpox. We will call it a herpes zoster. So that means that for a patient to suffer from herpes zoster, that patient should be a patient who have experienced varicella zoster virus infection before, like a chickenpox infection before. Is that okay? Great. So usually, if you want to diagnose whether a patient is having herpes zoster, you have to find out whether they've suffered chickenpox before. You have to do history taking and find out whether the person has suffered chickenpox before. If the person has suffered chickenpox before and the infection is caused by varicella zoster virus, now the condition the person is currently having is herpes zoster. That's the shingles. Is that okay? Pay attention and know the difference. Okay, great. All right, that is fine. So I do I do some, 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 I do Good. So I try to do the different. There are times that they will intentionally ask you questions to see whether you can differentiate between the two. Okay, so I've done some differences over here for you to know how to differentiate between the two. Okay, so for shingles, usually for shingles, one of the cardinal signs is that it's more like a reactivation of a varicella zoster virus infection. Okay, so you see here, shingles occur when there is a reactivation. So someone who has suffered chickenpox and it is being reactivated, it is occurring again. Then we say it is shingles. Is that okay? Great. Now look at shingles, the locations that they commonly affect. They can ask you questions on that. So for shingles, it can occur at the side of the face. So you see the front side of the face. You see over here, shingles can occur there. Okay, shingles can also occur in areas around your eyes and even around your mouth. Areas around your mouth. Shingles can sometimes occur at your shoulders. You may see some of the signs at your shoulders. Okay, and one thing about shingles is that, let me show you a trick. One thing that you can know that a condition is shingles is, usually shingles are unilateral, meaning that it usually occur at one side of your body. Okay, so it's either it's occurring at the left part of your body or the right part of your body. That is one way you can know that a condition is shingles. It's usually unilateral. So if the examiner say, oh, a unilateral condition, patient is having a condition and there is a unilateral rash, automatically then you remember that this is likely to be shingles. Okay, it's usually you see the manifestation at one side of your body, usually with shingles. The manifestation will be specifically at one side of the body. Okay, great. All right, that is fine. That is fine. I think I have another diagram with another difference. So let's look at the good. So both shingles and both herpes zoster or shingles and then herpes simplex, they are all contagious conditions. Is that okay? They are all contagious. Again, more specifically, herpes zoster is caused by varicella zoster virus, more like a reactivation of a latent chickenpox infection. A patient who have suffered chickenpox before was not treated properly, then it reactivates again. It occurs again. Then this time we call it the herpes zoster. Is that okay? So, yeah, so that is it for the herpes zoster and then herpes simplex. Okay, now herpes simplex may usually be mild. Okay, but when it comes to herpes zoster, it's usually very severe and may be accompanied by fever, headache, and even fatigue. Is that okay? Great. All right. All right. That is fine. That is fine. Okay, so like I mentioned, the clinical signs, we have pain, we have the vesicular rash, burning sensation, and redness. I think many of you have seen chickenpox before, so you know how it looks like. But one key thing that will help you to identify in exams that the examiner is talking about herpes zoster is when they use unilateral rash. So remember, herpes zoster usually occur it affects or manifests at one part of the body, unilateral. Is that okay? So pay attention to that as well. Okay, now let's look at some. When it comes to the management, the medical management, we usually use antiviral therapy. That is the first line treatment because this is a viral condition. So the aciclovir, the valacyclovir, and all the other antiviral medications, alongside the pain management with NSAIDs and then neuropathic pain agents. Okay, at times too, they may do other topical agents like the calamine lotion, especially with the herpes zoster or the shingles infection. Okay, the nursing diagnosis to the priority one, acute pain and impaired skin integrity, is still.
Hello, sir.
Yes, please.
Sir, please, sir, are you recording it?
Oh, yes.
Some of us get joined on. We're not aware that we have class today.
Oh, you shouldn't be sleeping. No, we discussed this already. From now until you write the exams, you shouldn't be sleeping. You should
Oh, but
always
you
be
have
active. It's not an excuse. You should always be. Your eyes should always be open. All right, that is fine. Okay, that is fine. So we've done the herpes zoster and then the herpes simplex. Okay, so the difference is that with the herpes simplex, herpes simplex is usually, all of them, vesicles will be formed. The small vesicles will appear, or a group of small vesicles will appear. But herpes simplex may occur at different areas. It can be bilateral rash, meaning the rash may be on different parts of it, either the right part, the left part. But specifically, when it comes to the herpes zoster, with the herpes zoster, someone who have gotten chickenpox was not treated properly, then there is a reactivation. That is the herpes zoster, what we call the shingles. Is that okay? But if a patient is having that condition, usually there is what we call unilateral rash. The unilateral rash means that the rash is likely to appear at one part of the body, and that is what I showed you in the image. So you see over here, the rash is appearing in one part of the body. So check it very well. You see here, the rash is appearing in one part of the body. So you see, this one, if it is the left part, the rash would be lined up at the areas that it usually affects at the right part of the body. So you see here, the right front face, areas around the eyes and then the mouth, the shoulders. But you see, the condition is appearing at this area. Is that okay? This one is the shingles. Okay, the zoster. This one is the zoster. Unilateral. But the herpes simplex can be bilateral. That one may not be limited to one area or one part or one side of the body. It can be everywhere, all around your body. Is that okay? All right, that is fine. Okay, so I've shown some differences over here. Okay, so you see I mentioned that the grouped vesicles on erythematous base, which become painful. But specifically, here with zoster, there is a vesicular rash, okay, which is unilateral. Is that okay? Unilateral. Okay, great. Again, with herpes simplex, okay, herpes simplex usually reactivates from the trigeminal or the sacral ganglia. But when it comes to herpes zoster, it usually reactivates from the dorsal root ganglia. And those of you who have been solving past questions, you might have come across this before, the dorsal root ganglia. So the herpes simplex usually arises from, it reactivates from the dorsal root ganglia. But the herpes simplex one reactivates from the trigeminal or the sacral ganglia. So take note of that one too. So the zoster reactivates from the dorsal root ganglia. the simplest reactivates from the trigeminal ganglia. Is that okay? All right, that is fine. That is fine. And like I mentioned, remember I gave you areas in the body that the shingles or the zoster can occur. The areas in the body where the zoster can occur. And I also mentioned that all of them are contagious condition, but the herpes simplex virus is more contagious, very, very, very contagious as compared to the herpes zoster. All right, that is fine. Okay, and when it comes to the medical management here, they usually do the antiviral agents because it's a viral infection. So they do the antiviral agents. Okay, so we have eczema, or what we call the dermatitis. Is the same condition. The eczema and dermatitis is the same condition, no difference. Eczema and dermatitis is the same condition. Okay, now when we say dermatitis, this one is non-infectious inflammatory condition of the skin. So eczema is non-infectious. Okay, it's a non-infectious inflammatory condition of the skin. You see all the skin conditions, the integumentary system conditions we've been looking at from the top, from furuncle, carbuncle, cellulitis, cellulitis. We also look at the herpes zoster, the herpes simplex, the folliculitis. You see, all of them are infectious and inflammatory in nature. Now, this one is a non-infectious inflammatory condition of the skin. There is no organism behind the occurrence of a dermatitis. That is one way you'll be able to differentiate between dermatitis from the other conditions. It's non-infectious. Now, this condition is usually as a result of allergic reactions. So your skin has been exposed to allergens. Your skin has been exposed to irritants. Is that okay? Or at times, it may be as a result of genetic predisposition. Genetics. So someone is genetically predisposed. So because we have some people that because of their bloodline, they have this condition. They have eczema. Is that okay? Great. So remember, this condition is a non-infectious inflammatory condition of the skin. Okay. So we have the usually caused by allergic reactions, irritants, and sometimes if you expose your skin to a lot of heat, you wear in a hot temperature, then you wear very tight clothing. Is that okay? Yes, you are likely to experience this condition. Or you live in a room where the place is very, very hot, very, very, very warm. You are more likely you're at risk of getting dermatitis or eczema. Okay, so so you see here, we are not talking about, unlike the other skin conditions where we have either a fungal agent, a viral agent that may cause it. You see here, we are not emphasizing on any viral agent causing this condition. We are not emphasizing on any fungal or bacterial agent causing this condition. Here, there are multiple factors that comes to play. And usually here, it's non-infectious, so we don't even talk about any bacterial or viral way. So here is the multiple factors, either an allergic reaction, you've taken in a drug that your body is reacting to, you've been exposed to some cosmetic agents, is that, or you are using a certain irritant like soap, detergent, or a chemical, or you are genetically predisposed. And usually if someone is getting dermatitis from genetic predisposition, we usually call that atopic dermatitis. Is that okay? All right, that is fine. Let's move on to so like I mentioned, atopic dermatitis. If someone is getting dermatitis because the person is genetically predisposed, we call that atopic dermatitis. And at times, someone can also get dermatitis from using cosmetic agents. Okay, wakwa kosra inkumbia your body is reacting to, you get dermatitis. That one, we call it contact dermatitis. So when you hear them saying contact dermatitis, meaning the person have gone to take in, let's say, a medicine, and because of adverse reaction or something, the person is experiencing them. That one, we call it contact dermatitis. Contact dermatitis. And then we have the seborrheic dermatitis. That one usually affects or occurs in the scalp and the face. So if someone is experiencing dermatitis, and specifically it is affecting the face and then the scalp, we call it seborrheic dermatitis. Okay, good. And someone can also experience dermatitis due to poor blood circulation, and we call that stasis dermatitis. Okay, good. So yes, and dermatitis usually itches as well. So one of the critical signs of this condition, or the cardinal or key signs, is the pruritus. Okay, so we have the redness or erythema, and then we have the pruritus. All right, so that is it for, and like I keep on saying, when it comes to skin conditions, remember, it's an area they usually trick you with. When it comes to skin conditions, the preferential diagnosis is usually the clinical examination, or what we call clinical diagnosis. Before any other diagnostic test will even come into your mind, here we prefer you use when it comes to integumentary system medicine and surgery, the clinical diagnosis is usually the preferred way of diagnosing the condition. Okay, so don't forget that one in the course of your studies. All right, now when it comes to the medical management, when it comes to dermatitis, usually we want to do corticosteroids, anti-inflammatory agents. So they usually do topical corticosteroids as the first line treatment, the hydrocortisone, the beta-metazone. Okay, then they also do the antihistamines. Okay, so they can do antihistamines. Okay, and sometimes they will do emollients, so like the moisturizers to help restore the skin barrier. They can also give antibiotics like the flucloxacillin. Okay, there are times they will give antifungal agents like the clotrimazole. Okay, yeah. So this is how they manage patients with eczema. It's the same as dermatitis. Okay, good. All right. So basically, these are some few. Good. We didn't do psoriasis. We've not done psoriasis. So this one over here, you are seeing over here is psoriasis. Now you can see clearly that, you see, this one looks like a scale. You see, it looks like a scale. So it's like a scale. It's like a dry scale. Okay, so psoriasis is also a non-infectious autoimmune. Now the difference is that, you see, psoriasis is autoimmune condition of the skin. Okay, autoimmune. So your immune system is affecting the skin. That one is psoriasis. Okay, so psoriasis is also a non-infectious, just that it is autoimmune. You see, and that's the difference. That's how you'll be able to understand psoriasis and then dermatitis. You know, dermatitis is not autoimmune. Dermatitis may be as a result of allergic reaction, genetic predisposition, you've been exposed to irritants. But psoriasis is non-infectious, but this one is autoimmune. That's the difference. Okay. And again, with psoriasis, we are going to see some dry, silvery scales. Look at this one. You see, it's like dry, silvery scales at the affected area. Look, you see how it looks like. This is how psoriasis usually occurs. So when you see the examiner pointing to dry, silvery scales, they are talking about psoriasis. And if the examiner is also talking about an integumentary system condition that is autoimmune, the examiner is talking about psoriasis. It's an autoimmune disease, and it's characterized by this dry, silvery scales. Is that okay? That is what we call psoriasis. Okay, so look at the image over here. You can see it's like a scale has formed on the skin. Dry, whitish, or they use the word silvery scales. Then they are talking about psoriasis. Remember, this one is autoimmune condition. This one is an autoimmune condition. So your immune system is fighting. And I told you that the cardinal sign of this condition is you may see the red raised plaques, which later tend to become a silvery white scale, like you are seeing in the image. So usually you see now it's dry, but initially when it starts, it's like a plaque. When we say a plaque, it's like a vast area of your skin has become reddish. And at the latter stage, it becomes silvery, dry, or whitish, dry scale, just like you are seeing in this image. But initially, when it starts, it looks reddish. Then later, it dries up to become a silvery, white scale, like you are seeing in the diagram. Okay, so this one is autoimmune condition. Okay, so the patient may experience itching, cracked skin, and that may lead to bleeding. The patient will experience burning sensation, thickened nails. Patients may experience joint pain and symmetrical distribution. Okay, like I keep on saying, with integumentary system conditions, we prefer that you use the clinical history or the physical examination to diagnose better than any other diagnostic test you can think of. All right, so here they usually give topical corticosteroid agents, and sometimes they'll give vitamin D analogs. All right, that is fine. That is fine. So the last one I think we will do for the integumentary system conditions. The last one we will do for the integumentary system conditions is the systemic lupus erythematosus. This is the last one we are doing for the integumentary system condition. Oh, I think we've not even done burns. Yes, we've not done burns. So we will do, let me quickly walk you through the systemic lupus erythematosus. Okay, so look at the systemic lupus. So the systemic lupus is also an autoimmune disease, but here is a chronic autoimmune condition. Okay, but the difference is that you see all the other, like the psoriasis. Let's go back to the psoriasis. So look at the psoriasis. You see, psoriasis is autoimmune, but you realize that the manifestation is only on the skin. Keep it in your mind. Psoriasis is autoimmune, but the manifestation is only on the skin. But come to systemic lupus erythematosus. Now, this is also considered as an integumentary system condition. It's also chronic autoimmune disease. But the difference is that the manifestation is not only on the skin. Let me take that again. Now, let's go back. Look at the psoriasis. Psoriasis is an autoimmune, non-infectious condition that affects the skin. You see, with psoriasis, the manifestation is only on your skin, meaning you are going to see the clinical sign only on your skin. Now, when it comes to lupus, even though it's integumentary, it's also autoimmune like psoriasis, but systemic lupus or lupus will not manifest only in your skin. It will affect your skin, it can affect your joints, it can affect your kidney, it can affect your heart, it can affect your lungs, and it will also affect your nervous system. That's the difference. Psoriasis only affects targets and affects the skin. Lupus can affect multiple areas. In fact, every organ in your body. So lupus can affect your skin, it can affect your joints, it can affect your kidney, it can affect your heart, your lungs, and your nervous system. So listen, if a patient experiences lupus, in fact, lupus is very easy to identify in an exams. Okay, so it's an autoimmune condition, specifically having manifestation in the skin, but alongside the skin, there are manifestations from other organs being affected in the body. Okay, so if a patient is having systemic lupus, it's a serious condition because you are going to see patients may even end up having pleuritis or pericarditis. Patients may end up having oral ulcers. Patients may end up having arthritis. Can you imagine that? A patient having an autoimmune condition and manifestation in multiple organs in the body. Just that one major manifestation is in the skin. That is why we've classified this condition under integumentary system. Okay, so one of the major ways we can identify lupus is its impact on the skin. But this condition, even though integumentary, affects all organs in your body. So lupus would manifest in your lungs, in your heart. It can manifest as pericarditis. In your joints, it will manifest as arthritis, just that it's non-erosive. Okay. In your nervous system, the patient will become photosensitive. Is that in your blood, these patients can experience anemia. A patient with lupus can experience anemia. In fact, in some situations, patients may even experience leukopenia. Okay. In the kidney, patients can experience lupus nephritis. Lupus nephritis. Okay, in the nervous system too, patients may experience seizures, patients may experience psychosis. So you see how different lupus is. So even though we are classifying this condition under integumentary because one of the major organs it affects or manifests in is the integumentary system, the skin. But this is an autoimmune disease that can affect several organs in your body. Lupus can affect your lungs, lupus can affect your kidney, lupus can affect your joints and manifest as arthritis. They usually become photosensitive. Okay, the rash that occurs in lupus is photosensitive in nature. Okay, again, lupus can affect your blood and manifest as anemia. Is that okay? And in the nervous system, this condition can manifest as seizures and psychosis. And this makes lupus very different from the other conditions. Okay, and usually in some books they call it systemic lupus erythematosus. In some books they will just be simple and say lupus. It's the same thing. Okay, so remember, this is also an autoimmune disease. The difference between this and psoriasis is that psoriasis usually manifests in the skin. You see, psoriasis is usually manifesting in the skin tissues alone. But lupus, apart from the fact that there will be a manifestation in the skin, it also affects other organs in the body. Okay, so patients can even experience oral ulcers or ulcers in the mouth. It can affect the lungs and cause pleuritis. It can affect the heart and cause pericarditis. Okay, it can affect the blood for anemia to occur. Is that okay? And again, patients will experience neurologic signs like seizures and psychosis. Okay, yes, and that is what makes lupus very interesting. So apart from the fact that it can manifest in the skin, and usually on the face, your patients would sometimes experience a butterfly rash. That is one of the cardinal signs of systemic lupus, a butterfly rash. Okay, so you see here, lupus can even affect your muscles. It can affect your joints. Okay, it can affect, and usually patients with lupus are photosensitive. Okay, in the nervous system, patients may end up experiencing seizures. This condition can affect the heart and inflammation of the heart and cause pericarditis. In the lungs too, it can cause inflammation, pleuritis. Is that okay? And then it can cause poor circulation of blood into the fingers and toes. Okay, so that's what makes, so you realize that lupus is very unique in nature compared to psoriasis, which is limited or restricted only to the skin. Okay, lupus goes beyond the skin and can manifest in several other organs, causing damages. Okay, and here with lupus, we usually give anti-inflammatory and immunosuppressive therapy. Okay, anti-inflammatory and immunosuppressive therapy. So like the hydroxychloroquine and then prednisolone. Okay, so we give anti-inflammatory and immunosuppressive therapy. All right, so basically that is it for lupus. Now, another condition called the Kaposi sarcoma. Now, Kaposi sarcoma, here we are talking about a cancer affecting, you already know cancer already. So I'm not going to talk about the cancer characteristics. Kaposi sarcoma simply means cancer of the skin, that's all. It simply means cancer affecting the skin. So look at how it looks like. So you see, this one is a cancer. You can say malignant tumor affecting the skin. Okay, Kaposi sarcoma. Malignant tumor affecting the skin. So you see how bad this one looks like. Yes, this one is Kaposi sarcoma. It's cancer affecting the skin. The same causative the same causative factors like the general cancers that we learned. But usually if someone is having HIV/AIDS, this condition commonly occurs. It's one of the manifestations that can happen when a patient gets HIV/AIDS. Okay, or conditions that impact on the immune system. Okay, then we even have the squamous cell carcinoma. That one too is cancer of the skin, different type of cancers of the skin. So the cardinal signs, there is purple, red, or brown skin lesions. Okay, and the lesion will keep, because it's cancer, so the lesion will keep progressing over time. You know, cancer goes through progression, promotion, and then metastasis. It can even start spreading. So you see, it is spreading. You see, it is spreading so well and so fast. Is that okay? Great. So that is Kaposi sarcoma. So, and it's very common in patients who are having problem with immune deficiency, and that's why it happens a lot in patients with HIV/AIDS. Okay, so the differential diagnosis, like I keep on saying, we use the clinical examination or diagnosis or the physical examination. Okay, and with Kaposi sarcoma, sometimes they may have to do surgery to remove the lesions. Okay, that is fine. Now, almighty burns. Okay, burns. Yes, so for burns, it's something you know already. Burns would usually affect the skin integrity, which it can be caused by heat, exposure to heat, electricity, or electrical burn, chemical, radiation, or friction. So we have several ways burns can happen, or several causes of burns. So we can have a thermal burn. A thermal burn, when a burn is caused by exposure to a hot liquid or a steam or a flame, we say there is a thermal burn. If someone experiences burn from a high voltage or a low voltage electricity or electrical exposure, then we say there is electrical burn. Okay, if someone also experiences a burn by coming into contact with acids or alkalines or corrosive agents or chemicals, we call that a chemical burn. If someone also experiences a burn just by being exposed to radiation, we call that radiation burn. Okay, so we have the thermal burn, we have the electrical burn, we have chemical burn, we have radiation burns, and we have frictional burns. Okay, so you know, burn can be as a result of poor safety practices. You are working somewhere, you know, you are working with heat, you don't observe safety practices, you can be exposed. Children are also very much exposed. Elderly people are also very exposed to getting burns. Now, when it comes to burns, the classification is very important, especially when we are looking at the classification by the depth. Okay, so classification by the depth, we have 4 classifications. We have superficial burn, or what we call the first degree burn. Superficial burn, when we say superficial, it affects the dermis only. Such a burn, we also call it the first degree burn. Now, the next is the partial thickness burn. This one affects the epidermis and part of the dermis. We call that partial thickness or second degree burn. It affects the epidermis and parts of the dermis. Then we have the full thickness burn or the third degree burn. Now, this one affects the entire skin. So here, the entire skin is destroyed. We call this the full thickness or third degree burn. Then we have the 4th degree. In fact, the 4th degree is very serious to the point that it can go so deep to affect your muscles or a bone. That is the 4th degree burn. Okay, great. Yes, some books may classify burn according to the cause, but we will not concentrate on that. Understand, because they can ask you question here. So if we say superficial, and I think in our previous meeting, when we were going through the past question, we saw a couple of questions on this. If we say superficial burn, it means a burn that affects the dermis only. That is a superficial burn. It affects the dermis only. Superficial burn. Now, partial thickness burn affects the epidermis and dermis and part of the dermis. Full thickness burn affects the entire skin, so meaning the epidermis and then the dermis. Okay, and even the hypodermis. Okay, good. Then we have the 4th degree burn. The 4th degree burn extends to affect muscles and bones. Now, let's look at the cardinal signs of this condition, burns. Now, you know, burns too is characterized by erythema. Now, if you've realized, all the integumentary system condition, a common sign that runs through all is redness and erythema. If you've been paying attention very well, you realize that this very sign is a common sign that runs through all the integumentary system condition. Okay, but there are specifics. Okay, apart from that, pain also runs through, swelling runs through, and warmth or heat around the site also runs through. Now, but then when it comes to specific types of burns, some specific types of burns or classifications also comes with unique signs. For example, if you take a full thickness burn, the patient will usually lose sensation because usually the nerves are usually affected. So if you take a full thickness burn, you see, with a full thickness burn, there will be loss of sensation. There will be loss of sensation. Okay, and if a patient experiences a partial thickness burn, usually blisters will form. If a patient experiences a partial thickness burn, usually blister formation would occur. Okay, great. And at times, patients will lose fluids, and that can lead to hot shock. If patient experiences especially severe burn, fluid loss would occur, and dehydration can also occur. And if care is not taken and resuscitation is not done, patients may end up experiencing shock. Okay, good. Now let's talk about the Wallace rule of nines. Let's talk about the Wallace rule of nines. Now, with the Wallace rule of nines, if a patient experiences burn and the burn is affecting the head and neck, you assign a percentage of 9%, or you assign 9%. If a patient experiences burn and it affects the head and neck, you assign 9%. Okay, Now, if the burn is affecting the head, the entire head, it's 9%. The head and the neck, 9%. Now, each arm is also 9%. Okay, so that means that the front arm is 4.5. That's the anterior arm alone is 4.5. The posterior arm is also 4.5. So if the examiner tells you that a patient has suffered burn of the right arm, if it is the right arm alone, it's 9%. 9%. If it is both right and left arm, each of them 9%. So right arm 9%, left arm 9%. But if the examiner goes specific that, okay, anterior right arm, anterior left arm, anterior right arm is 4.5. If the examiner says posterior right arm, that one too is 4.5. So take note. Okay. All right. That is fine. If the examiner highlights on the leg, each leg is 18%. The anterior leg is 9%. The posterior leg is also 9%. So if the examiner tells you that the patient have experienced a burn of the right leg, the anterior right leg, that is 9%. Okay, if the examiner says a patient have experienced burn, it affected the anterior right leg and anterior left leg, meaning 9% plus 9%. So the anterior leg alone is 9. The entire leg is 18. The anterior is 9%. Posterior is 9%. Keep it in your mind. Now, the entire trunk is also 36%. The anterior trunk is 18%. Posterior trunk is also 18%. So the entire trunk is 36%. So all the time, be careful. If the examiner don't put anything in front, use all. If the examiner says leg, then straight away you are going to use all, which is 18. But if the examiner says anterior leg, then 9%. Okay, if the examiner says trunk, 36. Anterior trunk, 18. Now, even the anterior trunk, we have the chest and then the stomach. If the examiner says chest, it's also 9%, stomach, 9%. Because you see, the trunk also have the anterior region, the anterior trunk, the anterior trunk. Okay, so if you take the anterior trunk, we have the chest region and the stomach region. The chest region is 4.5%. The stomach region is also 4.5%. Is that okay? Sorry, 9%. And then the stomach region is also 9%. So if the examiner tells you that the patient have experienced burn and it affected the posterior trunk, listen, the posterior trunk. Okay, remember the posterior trunk, we have the chest region of the posterior trunk, and then we have the stomach region of the posterior trunk. The chest region of the posterior is 9. The stomach region is also 9. If you put the two together, 18. If the examiner emphasizes that it's the chest region alone, the chest region of the trunk, listen, chest region of the trunk, remember the chest region of the trunk, we have the anterior chest and we have the posterior chest. That one too will be 9 plus 9. That one too will be 18. If the examiner says the stomach region of the trunk, listen, the stomach region of the trunk, that one too will be 9 plus 9 because the stomach region, we have the anterior and we have the posterior. So that one too will be 9 plus 9. Okay, so if the examiner says trunk, they didn't specify, you use all, 36. If the examiner says anterior trunk, that one you use 18. If the examiner says posterior trunk, 18. Now the same trunk, if the examiner says chest, the whole anterior trunk, if the examiner says chest, remember the chest, we have posterior chest and anterior chest. The chest too will be 18. If the examiner says stomach, remember and don't specify the stomach, we have the anterior stomach and posterior region of the stomach. That one too will be 18. So you always have to be smart. Is that okay? Good. And then the perineal region is 1%. Now, there are times the examiner can bring some, informal ones to confuse you, like the arms. You see, the inside your palm, okay, inside your palm. We usually assign 1% to your palm. So sometimes the examiners can intentionally bring some insignificant ones to come, like a patient's surface burn in the palm region here. You see here, if you see palm region, just assign 1%. The palm in Ben's Wallace rule of nines, the palm usually assign just 1%. Is that okay? So here too is 1%. So usually the palm we just assign 1%. So if the examiner brings in the palm, just assign 1% to the palm. Okay, so that is fine. So I think we are good with the calculation. So with this, if we should give you, we should ask you to calculate for the total bend surface area. I know you'll be able to do the calculation. So yes, so with bends, we give the painkillers. With the management, they can give painkillers. Now, when we are doing in bends, because patients can lose fluid and get dehydrated, and if resuscitation measures is not done properly, patients can experience a shock. We usually have to do what we call fluid resuscitation. And the recommended fluid to use in bends is Ranger's lactate. Ranger's lactate. Yes?
So you said that the head and the neck is 9%. So if it is only the neck, how do you calculate it?
The neck too is an insignificant area. All insignificant area, usually you assign 1%. You see, I was telling you some areas in the body are insignificant, like the palm. Any insignificant area, if the examiner points that part alone, most of the time, if the examiner just writes the head, is both the head and the neck inclusive. But if the examiner should say head, neck, the neck assign 1%. It's an insignificant area. If the examiner, the palm is also part of the hand. Do you know the palm is also part of the arms? But if the examiner intentionally brings the palm in the scenario, assign 1% to the palm. Okay, the neck is also an insignificant area. If the examiner happens to mention it, assign 1% to it. Is that okay? So if the examiner intentionally highlights that the neck region, the neck, assign 1% to it. The same thing, the palm. If the examiner says palm, assign 1% to the palm. It's an insignificant area. But if the examiner says the head, okay, straight, that is 9%. If the examiner says the anterior head, that one you give 4.5. If the examiner says posterior head, it's 4.5. If the examiner says face, it's 4.5. Is that okay? If the examiner says occipital region, it's also 4.5. So they have several words they can bring just to trick you to be sure that at least you are competent with identifying the parts they are talking about. Okay, so if the examiner says, chest region of the body, what percentage will you give? Chest region of the body. Chest region of the body, what percentage?
So it will be
The examiner
18.
says 18. Yes, that is correct. Why 18? Because the chest, we have the anterior chest, which is 9. Posterior chest is also 9, 18. Okay, if the examiner says the chest region of the body and anterior stomach, what will be your answer? The chest region of the body and anterior stomach, what will be your answer? Yes, the chest region of the body and anterior stomach.
I think that would be 27, right?
That is 27. Yes, because the chest region, we have 9 plus 9, which is 18. Then the anterior, you see, I was very specific that anterior stomach. Is that okay? So that one, you just add 9. So 9 plus 9 plus what? 9. Is that okay? So always pay attention so that they won't use some of these things to trick you. Okay. If the examiner says anterior arm, posterior leg, anterior arm, listen carefully. Anterior arm, anterior arm, and then posterior leg. What will be your answer? Anterior arm, posterior leg. What will be your answer?
0.5.
Come again.
0.5.
You see, I managed to trick you. Now, if the examiner brings the leg, didn't add right or left, use all. If the examiner says leg, did you hear me adding right or left? No. If the examiner fails to bring right or leg, use all. So if the examiner tells you anterior arm, you see here, we didn't say anterior right arm. Use the two. That's the trick. So anytime the examiner says anterior arm, the examiner didn't tell you right or left. Use the two. Because here we didn't tell you that you see the arm, we have two. So if the examiner says anterior arm, you use the two. So 4.5 plus 4.5. Then I also mentioned posterior leg. So that one to the entire leg is 18. So that one to 9 plus 9. So you have to be smart. If the examiner says leg, you use the two. If the examiner says right leg, that is when you use one. Always be smart. So the moment the examiner says leg, in your calculation, you use the two leg. But if the examiner goes straight, right leg, then you use one. Is that okay? So always be very smart. That's the same way if the examiner says trunk, you use all. If the examiner says trunk, you not use the anterior trunk. You use the entire trunk. So it becomes 36. But if the examiner says the anterior trunk, then you use 18. If the examiner says posterior trunk, you use what? 18. If the examiner says the chest region of the trunk, that one you use the 9 plus 9, the same 18. If the examiner says the stomach region of the trunk, that one to 9 plus 9. But if the examiner says the anterior stomach region, then you use 9. If the examiner says posterior stomach region, that one you use 9. If the examiner says leg, you use the two leg. You only use one leg when the examiner says the right leg, then you use the right alone. If the examiner says the left leg, you use the left alone. But if the examiner says leg, you use the two leg. If the examiner says arm, you use the two arm. But when he says right arm, you use only the right arm. When he says left arm, you use only the left arm. Is that okay? Yeah. So that's how simple the Wallace rule of 9 calculation is. So like I was saying that in burns, because of the fluid loss and dehydration, which can increase patient rates of suffering from patient rates of experiencing shock, we usually do fluid resuscitation. And with the fluid resuscitation, the recommended fluid we use in burns is the Ringer's latex. Is that okay? The Ringer's latex. Okay, and at times with burns to tetanus prophylaxis is also very important. So they usually give the tetanus tozoid vaccine. Now, the key thing I want you to also consider, a lot of people don't pay attention to it. They only learn the Wallace rule of 9, is that you have to know how to do the fluid resuscitation calculation. Okay, and the formula we use, we call it the Parkland formula. The Parkland formula. So with the Parkland formula, this is what you are going to do. Now, if the examiner gives you, the examiner will usually in MCQ, what the examiner will do is the examiner can give you the total burn surface area. If they are giving you a question that, okay, patients have suffered a burn affecting blah, 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 blah area, then the examiner will ask you, what amount of fluid will you use to resuscitate? That's how the question will be put. Now, in the question, the examiner will give you the body weight of the patient. This. And the examiner may ask you to calculate for the TBSA yourself, the total burn surface area yourself, or the examiner can give you the total burn surface area. Let me take that again. Now we use the Parkland formula. The formula says that you multiply 4 ml by the body weight of the patient, then you multiply it again by the total burn surface area. So I was saying that the examiner will always give you the body weight of the patient. And at times, the examiner will give you the total burn surface area. Or the examiner may let you calculate it yourself in the scenario. But the constant factor is that the examiner will always give you the body weight of the patient. Now, if the examiner gives you the body weight and then the total burn surface area, or if you have to calculate for it, you do your calculation to get the total burn surface area, then you put it in the formula: 4 ml times body weight times the percentage. Okay, then you get the fluid. So for example, let's say a patient's body weight is, let's say, 50 kg. And we did our Wallace rule of 9 calculation. We had 27%. So it's going to be 4 ml times 50 kg times 27%. Then the fluid that you get, that is the fluid that you use to resuscitate the patient. Okay, so the formula. So for example, the examiner has given you the scenario that the patient weighs, let's say, 50 kg. And the patient experienced burn which affected 27% of the body surface area. So in your calculation is 4 ml times the body weight multiplied by the burn surface area. Now the amount you get, that is the mLs of fluid, Ranger's lactate, you have to use to resuscitate the patient. But usually what you do is that the first 8 hours, we will give the patient 50% of that fluid. Then the remaining 16 hours, we give the rest of the 50%, the remaining 16 hours. So the examiner will ask you that, okay, a certain patient has suffered a burn. It affected 40% of the total body surface area. Okay, and the patient weighs, let's say, 70 kg. What amount of fluid is required to resuscitate this patient? It's simple. 4 ml times 70 kg times then the percentage. If it is 16% or whatever, you multiply. So 4 ml times 70 kg times 16%. You do your calculation. The amount you get, that is the amount of fluid that you use to resuscitate the patient. It's usually in mLs. The answer will be in mLs. But the trick is that the first half, the first 8 hours, you will give 50% of that fluid. So let's do an example. Let me give you some figures and let's do an example. A patient weighs 65 kg. Let's do, if you have your calculators, we can do an example. A patient weighs 55 kg and suffered a burn. The burn affected, the patient suffered a burn. The burn affected 25% of the body surface area. A patient weighs 55 kg, suffered a burn. The burn affected 25% of the body surface area. Okay, what amount of fluid is required to resuscitate these patients? Do the calculation and give me the answer. What amount of fluid is required to resuscitate?
Say it will be 6,500.
Good, 6,500 mils. Did you all get that? Okay, that is fine. Now, if the examiner asks you, okay, what amount of fluid will be required to resuscitate? That's the answer, 6,500 mils. But okay, if the examiner asks you, what amount of fluid will you use to resuscitate the patient in the first 8 hours? You see how I'm putting the question now? What amount of fluid will you use to resuscitate the patient in the first 8 hours? That one is 50% of the answer you've gotten. So calculate 50% of the answer you've gotten and let's see the answer you get. 50 divided by 100 times 6,500. What did you get? Yes.
But can you divide by 2 since all of them are 50%, 50%?
It will give you the same thing. But the principle is usually 50%. So for you to go through the normal calculation, it's 50 divided by 100. Then you multiply by the fluid that you had. Is that okay? So that you not explain it that it's divided by 2. It's not divided by 2. It's 50%. Even though mathematics will let you know that you get the same answer when you divide by 2. But in explaining, it doesn't mean divide the fluid by 2. We are saying 50%. Or some books will say half. You give half of the fluid that you've gotten in the first 8 hours. Then the rest, you give it in the next 16 hours. Okay, so if the examiner, so let's do another example. A patient weighs 70 kg and suffered a burn affecting 20% of the body surface area. A patient weighs 70 kg, suffered a burn affecting 20% of the body surface area. What amount of fluid will you administer or will you use to resuscitate in the first 8 hours? That's the question. In the first 8 hours.
You'll be giving 70% for the fluid.
So the weight of the patient is 70. The weight of the patient is 70. The burn surface area is 20. What amount of fluid will you use to resuscitate in the first 8 hours?
Say 700 ml.
Yeah, gentlemen, do your calculation well. Listen, in the first 8 hours. In the first 8 hours.
Yeah, I think that is it, sir.
Did you all get the same answer? Okay, let's do the calculation together. How did you get for the total fluid you need for the replacement? What did you get?
1,400 ml.
Okay, what was the weight of the patient?
The weight was 70%. I'm 70 kg.
Okay, so 4 times 70 times the burn surface area was what? 20. 20%. When you multiply, you get 5,600 mils. 5,600 mils. How did you do it? And so 4 times 70 times 20%, that is 5,600 mils. The first 8 hours, you give 50%. So 50%, that is 2,800 mils. Have you gotten it? Have you gotten it?
Yes, sir.
Yeah, so where did you make the mistake? Yes, where did you commit the mistake, the error? Yeah, so 4 times, you didn't multiply by the 4. So 4 times 70 times 20, that will give you 5,600 mils. And then you give half of that in the first 8 hours. And the question required you to determine the fluid you administer in the first 8 hours. Is that okay? Or you want to divide by 8. You don't divide by 8. You divide by, so that's why I told you do is 50 over 100 times the total fluid that you had. Or you can divide by 2. Is that okay? So 50, so 70, it will be 4 times 70 times 20. That will give you 5,600. Then 50 divided by 100 times 5,600. That will give you 2,800. Is that okay? All right, that is fine. So pay attention. So in burns, that aspect of the management is very, very important. Is that okay? Yes. So that is it about burns. Okay. If a patient suffer burns, that patient can, because burns, sometimes we do in burns, when you take burns, sometimes because of the fluid loss and dehydration, patient can experience shock. There can be infection. And because of the shock and the dehydration, patient can experience renal failure. Okay, and sometimes burns patient can experience respiratory failure as well. Burn is also one of the conditions that can easily influence patients' fluid and electrolyte balance levels. And in very severe cases, patients may even die. Is that okay? Yes. Now, again, in burns, this is a condition where we do the skin grafting. The skin grafting. Okay, so skin grafting, we are removing a healthy skin from a part of the body of the same patient or another person, okay, to help repair or facilitate repair at the affected part of another patient. Okay, and usually burn is usually indicated when patients suffer large burns. Okay, burn can also be indicated when patients suffer pressure ulcers, when patients suffer skin defects. Okay, when patient is having chronic non-healing wounds. These are all indications for grafting. Is that okay? Now, you remember we solved a certain question that they were asking the factors to consider when you are going to do skin grafts. Now, we have the patient factors. So the patient factors, good nutrition is a factor for a successful grafting to take place. You are going to do grafting for a patient. For it to be successful, there are some patient factors. These patient factors include good nutrition, adequate blood supply, absence of infection, controlled chronic diseases, age, and general health. Okay, now we have the wound factors. For a graft to be successful, wound factors also play a role. And the wound factors, we are looking at the recipient site where we are going to put the graft. We are going to do the graft. The recipient site. That site should be very clean. Again, the site should have adequate blood supply. The site where you are going to do the graft should have adequate blood supply. And there shouldn't be necrotic tissue at that site. In fact, there shouldn't be anything like pus at the site where we are going to do the graft. And there shouldn't be bleeding at the site where we are going to do the graft. Now, the third factor is that the graft factors. Now, the graft factors, you should consider the thickness of the graft. So if the area where you are going to put the graft requires that you graft with a thick skin, make sure you are picking a thick skin. The graft factors. Now, the size and shape match is also very important. The size and shape. Okay, and again, sometimes the color match too is important, especially when you are going to graft in the face. Okay, and then proper handling of the graft is also very important. So if you are going to do a graft for a patient, for the graft to be successful, you should consider the patient factors where you focus on good nutrition, adequate blood supply. There should be absence of infection. If patient is having chronic disease, you are going to do a graft, control the chronic disease. Okay, then we have the wound factors where you are going to do the graft. The wound factors is about the recipient site where you are going to put the graft. That site, the wound there should be clean. Again, the wound there should have adequate blood supply. Again, the wound there shouldn't be necrotic tissue or pus at that area, and that place shouldn't be bleeding. Else, if the place is bleeding, I will assure you the graft will not be successful. Now, the graft factors, the grafts that you are picking should match the thickness of the place you are going to put it. Again, the shape and size of the graft, you have to check and make sure you are getting the right shape. The color match too may be important, especially when you are going to graft the face. and then proper handling of the graft. Either than that, infection will set in. Okay, now we have types of grafting. With the types of grafting, we have the autograft, which is the very common one. Autograft, you are picking the skin from the same person. So the donor site will be on the same person. The recipient site will also be on the same person. Usually, it has the best survival rate. Okay, the autograft is the most common and it has the best survival rate because you see, the likelihood that you will react is not common because it's your own skin. We have the allograft or the homograft. You are taking a skin from another human donor. That one is not the same person. You are taking from another human donor, another human being, apart from that same person. Okay, so you take the graft skin, the donor skin from another human being. That type of grafting, we call it the homograft. So if it is a patient, you can take it from the husband or the wife or the child. Or if it is a child, we can take it from the mother. That one, we call it the allograft or the homograft. Homograft. Then we have the xenograft. The xenograft is when you are picking the grafts from an animal source. Sometimes they can use a pig skin. Sometimes too, they can use tilapia. Okay, so that one is called the xenograft. Xenograft. So when we say xenograft, meaning we are picking the donor side, the donor will be an animal. If we say autograft, from the same person, autograft. Allograft or homograft, from another person but a human being. Okay, from another human source. Okay, allograft or homograft. Xenograft, from an animal source. Okay, good. That is what we call the xenograft. Okay, so now if you are going to do a graft, when we say donor site is the area where you are taking the healthy skin. Is that okay? And usually, the common areas we usually pick healthy skin is the thigh, the buttocks, the abdomen, and the upper arm. Commonest areas that doctors will usually pick the healthy skin, the donor site, pick the skin from, is the thigh, the buttocks, the abdomen, and the upper arm. Okay, the thigh, the buttocks, the abdomen, and then the upper arm. Usually, donor site usually heals faster because those, even though when they pick the skin, there will be a wound there, but the wound is a surgical wound, very clean wound, so it heals very fast. And that wound can be very, very painful. I'm telling you, that wound can be very painful. Okay, and usually the donor side too have to be dressed very well to prevent infection. Then we have the recipient site. The recipient site is the site where the wound is, where we are going to graft or where the graft will be placed. That is the recipient site. The site where the wound is, where the graft will be placed, that is what we call the recipient site. And in fact, before you do the grafting, that site have to be clean. That site should be non-bleeding. It should be non-bleeding. There shouldn't be a necrotic tissue there. And the site should be well vascularized, meaning there should be adequate blood supply there. The site shouldn't be bleeding. The site should be non-bleeding, or it shouldn't be bleeding. The site should be well vascularized, and the site shouldn't be infected. There shouldn't be any necrotic tissue or pus at the recipient site. Is that okay? So pay attention to that. Now, after a graft failure can occur. The graft can fail. It may not pick. Now, after a graft, infection can occur. Hematoma can occur. The patient can bleed under the graft. Hematoma can occur. Seroma can occur. Necrosis can occur after an unsuccessful graft. Contractures can also occur. Okay, in fact, contractures are very common where the skin becomes very tight, okay, during the healing process. Is that okay? And at times, rejections can occur. Rejection is very common, especially when you are doing allograft. Rejection is very common, especially when you are doing the allograft. Rejections are very common. Okay, so after a graft, rejection can occur. There can be delayed healing. Contractures can form. Necrotic tissues can form. Infections can form. And graft failure can occur. Okay, yes. So basically, that is it about the skin grafting. Now, with the skin grafting, we have types. So, but the types also depends on the thickness of the graft, meaning the donor side that you are taking. Now, if the graft is you are picking epidermis and part of the dermis, okay, we call that split thickness graft. So if you hear the doctor saying that, oh, we are going to do split thickness graft, what it means is that graft, the donor site they've taken the epidermis and the dermis together. That one, we call it the split thickness graft. Now, if the doctors say full thickness graft, what it means is that they've picked the epidermis and the entire dermis. So anytime you hear, oh, doctors say, oh, they are going to do full thickness grafts, meaning that graft, they've picked the epidermis and the entire dermis to go and graft, to go and put at the recipient site. So when you hear split thickness graft, that one, they've just picked the epidermis and part of the dermis to go and place at the recipient site. When you hear full thickness graft, they've just picked the epidermis and the entire dermis to go and place at the recipient site. That is what we call the full thickness graft. Okay. All right. That is fine. So I think this brings us to the end of the integumentary system conditions. This brings us to the end. This is the last thing we will do in the integumentary system conditions. Okay. All right. So I think I'll end over here. So that you can rest. I'll end over here. If we have time, today, let me know the schedule. Either in the evening or late in the evening, we will do the special senses. Yes, so the special senses, we will go through glaucoma. We will go through the eye. We will go through glaucoma. We will do otosclerosis. We will do otitis media interna, otitis media externa. We will do Meniere's disease. We will do trachoma. We will do glaucoma. We will do cataracts. We will do chalazion. Yes, so we are left to do with the special senses. All right. I wish you guys all the best. Have a nice day. Bye-bye.